You guys probably ran into him, Dr. Travis Nelson, and I knew that he had some experience. He did the National Geographic, is that what it was? Him and Dr. Yerman do National Geographic and travel with them as their physicians, which is great, super cool. They need a nurse. So I knew he'd probably be a good one to hit up on doing environmental emergencies for you guys. So I'll turn the time over to him.
Thank you. Just as a segue for that, so that is kind of my fun hobby as a physician is going with National Geographic. So once or twice a year I get to travel with them, and they take a private jet with a bunch of rich people around the world to different various places, and they want a physician with them. So I'm fortunate enough to be able to do that. But because of that, a lot of exposure to a lot of different cultures and a lot of different illnesses, a lot of different medical systems in the world. And it's been really enlightening to me to see how our system works versus other systems. I didn't include a lot of that with my lecture today. But if that's something of interest, I'm happy to do more of a world emergency medicine type of lecture in the future if that's of interest to any of you guys. Today I focused more on more applicable things for our community, for our environment and environmental emergencies.
All fire units, you can log back into Stillman. You can log back into Stillman.
Hope you know what that means.
We do. Do you mind if we take just
Let's pause.
a quick break, since that is our own computers?
Yes, please.
Chris,
There's only so far you can go back on the
Roxanne,
chair.
I'll do this one.
Okay.
Sam, don't need that precious copy.
Yeah, we're changing to a new
Totally fine.
new program this morning, and that's how we run our world.
At the moment, this is not,
Is it not working? Oh, probably.
or do I need to point
No,
it somewhere?
I probably changed it, I can try to get.
Okay.
I changed it on you because they said they couldn't hear.
Oh.
Thanks, man.
Thanks for the tip on that.
They look.
You know what was amazing was just that first stuff you wipe it with, that by itself took all this. So much.
Oh, yeah.
Yeah.
Oh, yeah, because that's, all it is a break. You might as well just leave them here, because Christian will probably spill my coffee again.
You should have seen Cole this morning. Cole, took out Kelsey
Yeah, spill coffee all over Kelsey.
all over, I mean, half all over.
Yeah, all that is a breakdown of that laminate coating on plastic.
Rox, I'm gonna have to do this one later because I have to go download the new
That
database thing or
laminate
whatever
coating,
for that
Okay.
one.
Do, I'm like,
and that final stage, that like weird like super glue
Did you
smelling
guys already
stuff.
download it on
That's what that
the
laminate coating
vehicles?
kills it, yeah. and you cut
And
it
so
off.
all it does.
I
is
don't
just
know.
sand
If
it
they
down,
didn't, they'll
and
figure
then
it out,
that
'cause it's
is
in
what
Rico
that
in there right
laminate
now,
coating
so.
actually is, and that's why you sand it, is so that the nailing can stick to the plastic appropriately. Yep.
Well, they're not perfect, but with that right one, that's the one I sent you. So the left one's
See, we
still,
need to plug it
but
in.
it's still not like it was. It's really thick
Yeah.
in half.
I think Braylon might be
Yeah, it
good.
doesn't look like it has cataracts anymore.
No, yeah.
Yeah, I wish I still had some of the before and afters of when I used to do
There's
those
your
kids, because they were,
That was
okay.
something.
it was
Yeah,
seriously
I
like
wish I
night and day
did
difference.
before.
But you say they can hear them well enough, like if they
Yeah.
ask a question or a comment or something, I don't need to repeat it.
And Rox, we're recording it too, right?
Yes. In fact, I was gonna look at double recording.
Did you tell her what happened to Brayley? The other day we recorded one of the things, and we never shut off the recording,
Oh, no.
and so we were doing our chores and Brayley was in here singing, vacuuming, cleaning. There's a whole video of her singing, cleaning in the air.
That's awesome.
4 hours worth.
And they
She
won't let
wasn't
me,
here.
and they won't let me watch it.
I feel like everybody should see it.
I think so too. I wanna watch it bad, but Roxanne won't let me.
Please, ambulance is Fort Square, 321.
Hey Braylee,
What's up?
Ambulance 54.
how are you? We're not talking
We were just
about
talking
it.
about your audition tape.
Oh, Jesus. I hate you all.
We're gonna watch it when it's over.
Are you?
Yeah, Roxanne said we could.
Yeah, okay.
How Roxanne?
Recording in progress.
She said that for sure.
There.
She also said that you're her favorite firefighter.
I believe that.
I say a lot of things I don't remember saying.
That was kinda rude.
Put your big hands on.
Yeah. Did you have to re-download the new database?
I think
You
we're.
just
think
logged
it's
in
just
and it
with
said
that
morning,
computer.
it's changed to read only.
Yeah.
That what?
Do we have
And you still
to?
logged in?
He said we need to
I
download the
think you
new
need to download the new
one.
database.
Oh, is that, I thought you were talking about the ambulance, sorry.
No,
I think you're right.
Oh,
It's in the
for, I
email.
just did it as a tangent, I didn't do it for this.
yeah, I was gonna do it this, but I need to re-download it.
Yeah.
I don't know how to download the new database thing.
Well, nobody, we need to get like an email from Carl
Yeah.
to change our usernames before we can actually like log
No.
in.
But it was like
Versus
going to your
for
shared
the
fire and it was
monitor.
like do,
Yeah, for that one, we have to get a new
Oh, it
username
ended up
from.
there over there?
No. Maybe.
Just wait for one more and I think
I'd like
that's
that
it.
Christian.
Okay. Back on.
It's his fault, and he didn't think it up
Make sure you.
in front of his engineer.
Good job, Chris. Now I like you.
Paramedic agent 53, Fort Square, 321.
that's what we have to count
You guys ready?
Yes, sir.
Before we jump into this quickly, I just wanted to give a little, I don't know how much updates you guys get with hospital stuff, and so I just wanted to give you a quick little update about Davis Hospital. As you're probably aware, the ownership of Davis changed this year. We were initially owned by Steward Healthcare System. They sold to another company. At the beginning of the process, we were under the title of a Cerner was the company, but then they had some name changes and some administrative changes and so forth. So now the company's name is Common Spirit. And Common Spirit has decided to name all of the hospitals associated with us Holy Cross hospitals. So our official name is Holy Cross Davis. The owners of the hospital system is Common Spirit. Common Spirit is a very large healthcare system in the U.S. They have hospitals and clinics in, I believe, 21 or 22 different states, 142 different hospitals, and then they bought 5 here in Utah, including Davis being one of them. So we're super excited about Common Spirit. They have a lot of resources, they have a lot of experience, a great reputation. So we're excited about what they'll have to offer to bring in addition to what we already have at Davis. For a couple examples, they've already started putting in a fair amount of money into the hospital. New ultrasound machines, new AC units. They've given the nurses raises. They're evaluating more raises this month. So they're invested in our community and in our hospital, and I think it'll be a good asset. And they're one of these companies that are meant, when they buy something, they stay with it. They're not like Steward was and more of a business entity trying to make money. So I think Common Spirit's probably here to stay for some time, if not indefinitely. You know, and with all the changes and with Steward and so forth, we obviously had our own struggles. And you guys probably noticed one of the things was we were transferring out a lot of patients to other hospitals because we use you guys to transfer. I will tell you that has already significantly changed and will continue to change. We intend to keep all patients that we're capable of taking care of at Davis Hospital. Of course, if it's an extreme situation where they need to go, say, the University of Utah or something like that, then those transfers will happen, or primary children's. But you definitely will see a decrease in transfers. Our intent is to keep people in their community where they want to be, assuming we're capable of taking care of them. And we're capable of taking care of a lot. As you guys are aware, we're a stroke center, we're a trauma 2 center, we're chest pain accredited. So we take pride in all these accreditations and the quality. So we hope to continue to improve. And so we appreciate your relationship with us and bringing patients to us and helping us when we need it. And so because of that, as the medical director, I am open to feedback, open to suggestions, open to whatever you guys have from your standpoint that can improve us as a hospital and as a community. So please feel free to give me any kind of feedback or any concerns or desires or anything that you think we can do to help you guys, because you have a difficult job. And we recognize that. A lot of us ER docs were EMTs and paramedics and so forth before we went to med school, so we understand your perspective. I was never a firefighter, so I don't get that part. But with all of that logistics of Davis Hospital, any questions from you guys about the changes or anything that you have concerns of, or rumors or anything going around that you want to talk? I'm open book, so. I will say, if you have any issues, feel free to reach out to me directly or through Jalen or whomever. But also, if you guys don't see a significant change in transfers of people that should be staying at Davis, but we just haven't been able to take care of them because of nursing staffing was the main reason previously, I want to know, I want to hear your perspective from it. I will tell you that I'm looking at every transfer that we transfer out to see if it's appropriate or not. And so we're making headway with this. So, environmental emergencies, please, let's keep this open discussion. There's questions in here. If you guys will please respond, and let's keep it open. And if it's boring, tell me, let's move on, let's talk about something different, whatever. This is for you guys. So whatever I can do to help. So a few objectives. Recognize various environmental and patient conditions that can affect medical emergencies. You guys deal with this every day, so a lot of this you already know very well. Hopefully there's a little bit to learn as well. I wasn't able to, because of time restraints, able to talk about all environmental emergencies, so I'm just hitting on some of the big ones. And then not only discuss recognizing the environmental emergency, but treatment of such. And then there's an exam at the end. It really isn't difficult. It's just a few questions to make us think about environmental emergencies and make sure we understand the concepts. So obviously medical emergencies, we're talking about things that are involved with the environment, factors of the environment. So whether that's temperature changes, hot versus cold, can be water, whether that's moisture or a lake or a swimming pool. So water involvement, nature, things of nature, lightning, that sort of thing, and then living creatures. Various versions of living creatures can affect us and cause emergencies as well that live in our current environment. And then I want to talk a little bit about certain populations. There's certain populations that are higher risk of being involved with emergencies or having issues with emergencies, particularly the age extremes, whether they're very young or very old. They're susceptible to more emergencies. And then those with chronic illnesses. So your diabetes, your COPD, your cardiovascular disease patients, those types of things, those people are more susceptible to having emergencies and issues with emergencies. So let's start off with a case. You receive a call about a middle-aged male found less responsive at Layton Hills Mall. Okay.
Outside,
What's that?
outside.
So this is all the information you have. What are you thinking about when you're on your way there?
Panhandler.
Okay? How do you mean?
Just our homeless population, we've got
Overdose.
a few of them that hang out around there.
Okay, definitely, okay. So you have experience with homeless people there,
Overdose.
overdoses. Okay, what are some of the more common overdoses you're seeing?
Alcohol.
I'm sorry?
Alcohol.
Alcohol,
Fentanyl.
fentanyl. Yeah, fentanyl is the leading opioid overdose killer right now.
Isolated
Actually,
overdose, which drugs, I guess.
in America, actually, just read about this yesterday. In America, there's over 100,000 deaths from opioids a year. It's a huge issue. And as you guys know, fentanyl is more potent than the heroin, the oxycodone, the hydrocodone, that sort of stuff. And it's a huge issue because it's a lot cheaper. And so they can get a hit for $1. And the problem with fentanyl is not only its potency, but the drug dealers aren't specific about how much they're putting in each hit, right? Are they mixing it with something? Are they diluting it? Or is it straight up? And so the users don't know exactly what they're getting every time. And so that's why we're seeing a lot of deaths with fentanyl. So yeah, overdoses, huge issue. Any other things you're thinking about on your way?
Diabetic emergency.
Great. Perfect.
It's this time of year, you're thinking hypothermia possible.
Okay. Absolutely. Any other thoughts? Do you guys get nervous when you're on your way and you don't know what you're going into?
No. Not anymore.
Liars!
Not anymore.
You do too, because I still do sometimes. It's always nice to have that information, right? To have as much information as you can so you can prepare mentally. We all get nervous. That's completely normal. If maybe you're amazing, much more amazing than I am, but I still get nervous sometimes when I walk into a room and I don't know what I'm dealing with. All I know is they're unconscious. It's nice to have some history, right? Oops, sorry, wrong button. So we talked about some of the things on our differential diagnosis, some possibilities. So, what are you gonna do first?
Ammonia Anfield.
I'm sorry?
I wasn't actually, but I said ammonia Anfield. I was just saying ammonia.
Do you guys carry that still?
Yeah.
I wish we did. We don't have it anymore. I love that stuff. Yeah.
Use them all for his workouts. Yeah, we could have.
Okay, so after ammonia, what are you gonna do?
Check his
ABCs.
responsiveness and check his airway.
Okay, so you're gonna do your basic stuff, right? You're gonna do your ABCs. So, this is the scene. Any other thoughts? You haven't talked with anybody, you haven't talked with him. This is just your scene. Now what are you thinking?
See if he's alive.
No, somebody called and didn't check on him.
Yeah, somebody's a hero.
Happens a lot, right?
All the time.
All the time. Okay, so that's a possibility. What's worst case scenario?
Were you with me?
Stupid.
He's dead. Okay. What information can you get from this besides someone under a blanket? I guess you can't even tell it's a human. What's that?
Snow on the ground.
Snow, it's cold, right? Okay, so that gives you some information, as mentioned. So hypothermia, definitely a possibility. So, I'm your information, I'm your history, I'm your physical exam. You ask me what you want to know and I'll tell you.
Can we get him in the ambulance first?
Yeah,
It's cold outside.
You want to get him in the ambulance? You
I
can,
would-
yeah, you can do whatever you
yeah.
want, sure.
Did we check a pulse first?
Yeah, does he wake up?
He has a pulse.
Does he wake up, like, is he responsive talking to us?
Responsive, not really talkative.
Okay,
Arousable,
can he walk?
not well.
Okay, then we're just gonna carry him in an ambulance,
Okay. Okay.
and then we're gonna go from there.
What are you gonna check? What are you gonna do?
Check pupils, check sugar.
Okay. pupils reactive.
Temperature.
Get him blankets, crank the heat up.
It says vital.
So vitals, okay.
Cole has an opinion, hold on.
Is this, our dog has opinions? So heart rate's 54,
Not ideal.
how so?
It's a little low.
A little low, right? Compatible with life though, right? He's not dead. Blood pressure, a little soft, right? For the average male. Respiratory rate, 10. Thoughts with that?
How adequate is it? Like, is it, you know, shallow?
Here, does this give you
Poor
pulse
reading.
ox, poor readings?
Thank you.
Could be cold.
Yeah, it could be cold, our pulse ox.
So you're not quite sure on the adequacy, right?
You're gonna give
He's
him
breathing, he's not gurgling on his saliva per se, but it's a slower respiratory rate, and you don't know a pulse ox. Does that happen with you guys? Happens even in the ED, right? So sometimes we just can't get the vital signs, all of them.
The temperature, yeah.
What are your thoughts with that?
Blankets, turn the heat up. Hot packs.
So he's a cold guy.
Hospital.
Glucose. So not a diabetic emergency, right? Glucose is okay. Always something you have to think about with altered mental status. And there's your GCS of 10. So definitely altered, but not unconscious or anything. So, cold exposure, something very common, something that we'll deal with, that you guys deal with a lot. It's to the extremes that it's more dangerous, obviously. So that temperature was the key thing with his vital signs. That 90.5 was it? Hugely abnormal, right? So it may cause injuries just to exposed areas, hands, feet, nose, or it can be a systemic issue like this guy where it's an entire body experience that's causing him issues. So 5 ways in which the body can lose heat.
Conduction, convection, radiation, jinx.
Okay, there's 3 I heard. Conduction, convection, radiation.
Direct contact.
That's conduction, I'll give you a hint.
Oh, breathing.
Respiration. You can lose heat through breathing, right?
Yeah, we did.
Uno mas.
Evaporation.
Ooh, good. Who? Rox?
Evaporation.
Yeah. Evaporation. Okay. So conduction, direct contact, convection was convection.
So the air around you.
Yeah.
Air or water.
You think of convection oven, right? It's movement of air. Evaporation, moisture leaving your body, moisture takes the heat. Radiation, anything that's hot radiates heat, right? And then respiration. So with this guy, which of those are involved with this hypothermia?
All of them.
Probably all of them.
Probably not so much evaporation, but
It's like that, like snow.
If he's wet, yeah, absolutely possibility. So potentially all of these with this guy. So by definition, hypothermia is anything below 95 degrees. And then with a little bit of coldness, your body regulates, right? What are some of the changes your body does to regulate temperature when you start to get cold?
vasoconstriction.
Shivering.
Vasoconstriction, you get all your blood flow to your core, to your organs, your important things, right? Does someone say shivering? Yeah, movement, right? Shivering of your muscles, movement creates heat. But once you get to a lower temperature, you lose that ability to regulate, and that's when you get into trouble. And that's when key organs start to shut down. Just think of slowing of everything. The brain slows, the heart slows, the respiratory rate slows, everything just kind of slows down. And if not treated, it definitely leads to death. Recognize it doesn't have to be below freezing to become hypothermic? Those that are at risk, who can, before we go through these, throw out some things, people are at risk? Elderly, young,
Residentially challenged.
I'm sorry?
Residentially challenged people.
Love the politically correct.
Saying that.
Urban campers.
Urban campers.
It's kind of, it's like I heard recently, you guys know AMA, that gives medical advice, people that leave. Someone changed the term to self-decided discharge or something. I mean, just, it's that political correctness, but yes, challenged residentially, I like that. So homeless people, as mentioned, or those who don't have heat, say their heater breaks down. Those that are wet, so swimming accidents, drownings, that sort of a thing, wet humans evaporate a lot. And when they're in contact as well with water, the conduction part of it occurs as well. So anything that's wet. My dad taught me when I was a Boy Scout on winter campouts. It was maybe a little extreme for a parent to say, but he would say, you get wet, you die. I mean, that's a simple concept, but in reality, true. So wetness is huge for hypothermia. And then as mentioned, the pediatrics, geriatrics, and so forth. Burns, you lose your protective ability, right, with your skin. So those people get hypothermic pretty easily. Infections, your whole system's having a difficult time, your septic, that sort of thing. Those people get hypothermic. One of the sepsis signs is hypothermia, right?
Heat intolerance?
I'm sorry?
Heat intolerance?
Sure. Yeah, how do you mean by that? What do you
Like,
expound?
basically your body's not able to regulate like, heat and cold.
Yeah. Yeah, we all know that some people are better at being at a warmer temperature than others, right? So before the temperature goes too low, there's 4 stages essentially, and we'll just cruise through this. So we talked about starting from kind of left to right, you start shivering, you get vasoconstriction, and then as that progresses, your muscles stiffen, you lose coordination. You ever seen somebody who's so cold they have a hard time walking or hard time moving? They just lose that coordination of those muscles. The respiration slows, the pulse slows, and then the mental status slows as well. And then eventually they become unconscious. They can have dysrhythmias. What's a classic EKG finding?
Bradycardia and then AFib.
Bradycardia, okay.
PEA.
Yeah, so at the extremes, PEA or AFib. Is there this is a stupid way of asking it. I'm asking you, what am I thinking?
Specific waveform,
Yeah, a waveform or an EKG finding.
the J wave.
Yeah. What is that?
I can't remember what it is.
Come on, green patch.
Good recital of information though.
I was the only one that got it, so.
Who can help him?
Come on, paramedic students.
Corey?
I should have.
J wave probably has a shape similar to a J, but that's my gotcha.
I should have given you an example. I apologize, but I'll just describe it to you. It's a little blip after. It's a wave after the QRS. Oftentimes, it's before the QRS even ends. As the waveform is going down, you get an upright, almost like a small little T wave that's connected to the QRS, but the T wave's outside of it. So it's a little blip just on the end of the QRS, which is very pathognomonic for hypothermia.
What is that called?
The
The J
It
wave.
is the J wave.
J wave, yep. Good job. So this is a spectrum. It's not always cut and dry. People are going to transition and get worse as they go through the process. So local cold injuries, these are probably what we're most familiar with, things that are exposed to the cold. So hand cold injuries, nose, we probably all have seen this, particularly the homeless people, the nose exposure, feet, right? So all these extremities or things that are on the outer surfaces of our bodies, after our body vasoconstricts, they're not covered, it gets exposed to the cold and injured. Frost nip is the beginning of it. The skin may freeze, but the deeper tissues are okay. So there's not permanent damage. Again, usually the ears, nose, fingers, this sort of a thing. It's usually not painful. When we're outside in the cold and we start feeling pain in our ears and our nose and so forth, that's not frost nip. It has to go a step further to get to frost nip, and it actually doesn't hurt as much when that occurs. And then if you go deeper, then you have frostbite, and that's the more ugly looking stuff that you sometimes will see. The deeper tissues are affected, and they actually die. They're frozen. And so subsequently for treatment, assuming they survive, if it's not too serious, they oftentimes have to have debridement or amputations because that tissue's dead. Treatment. Obviously ABCs, right? You always start with the ABCs. But then get them out of the cold. Stop the cold damage that's occurring. Remove them from the environment. Put them in your ambulance. Perfect. Remove any wet clothing. Get them undressed if they're wet. Get it off of them. Get them dry. And then start the rewarming process, which is your heated ambulance, your blankets. Do you guys have warm IV fluids? Perfect. That'll help them. Do you know of any of the things we do in the ED that's maybe a little more aggressive?
Bear hugger.
Bear hugger. Describe a bear hugger.
It's kind of like continued warm circulating air. It puts them in like a little capsule and then it just circulates warm air around them.
Yeah, exactly. It's like this blanket that fills with air, and you put it all around them, and it's like a convection oven. Just circulates warm air around them. Okay.
Have you ever tried it?
I've never been in one.
Sounds wonderful.
It's a good idea.
I want to know your experience.
When we're slow, come on in and let's try it.
You want me to come for it?
Anything else
We should save it until like February.
that we can do in the ED for aggressive rewarming? I've never done this, but it's an option. You can put a chest tube in them and put warm fluid in through it and then suck it out. You can imagine that rewarms their core very quickly. So in extreme cases, that's what we're taught to do. Even if they don't have a pneumothorax, they don't have a hemothorax, you put a chest tube in them, put in warm fluid, suck it out. It'll warm them up really quick. Something we do frequently do is the same concept, but with a Foley catheter. We'll put a Foley catheter in them, we'll flush it with warm water. As you can imagine, your bladder up in here, close to your intestines, close to your core, getting warm inside, internally. Okay? Questions about hypothermia or any cold-related injuries? Pretty common, yes?
Will they use ECMO to warm them up?
I'm sorry, say again?
ECMO.
I can't say I've seen it done, but I don't see why not. The problem with that I can see is just the time intensity to get it prepared and so forth. It's a great question. I think theoretically, sure, that would work. Absolutely would work. But whether it's logistically doable, that you can do it quick enough to salvage a life, I don't know the answer to that. It's a good question. I'll have to look that up if that's been done. Any other cold-related questions? Ready to move on? Case 2. You get a call about an infant now in the Walmart parking lot Initially had some vomiting and now with some decreased mental status. What are you thinking on your way there?
There's a kid in the car, left in the car or something.
Okay, so possibility, you don't know
What time of the year is it?
what time of the year it is, okay?
Possibly head injury?
Sorry, head injuries?
Head injury, like if it's a kiddo.
Yeah, vomiting, head injury, yeah, altered mental status, absolutely. Is there some sort of trauma related to this?
Did they get into something they weren't supposed to?
Great. Overdose of something. So toxicology. What other medical issues potentially?
It could just be sick.
Could be sick. Some gastroenteritis, some viral illness, yeah.
Good.
What if they're diabetic, right? Altered mental status. So these are all things that are on our differential as we're driving there. Things that will help guide us as to what we do and what questions we ask, what information we gather as we're on scene. What are some of the things you're gonna do first?
Get a blood sugar.
Sugar?
Is family there? Family would probably be like your best resource for like questioning. 'cause
History is
you
gonna
can't
be
talk to.
super important.
And how old is the kid? Like, can the kid communicate with us?
Yeah, great question. All you know is an infant, so what does that mean from
Let's
the
get
call?
them in a controlled environment, so like the back of the ambulance.
Yeah,
over there.
absolutely. And then, of course, your basic, your ABCs, your vital signs, right? That's some of the first things you're gonna wanna do. This is what you see when you come on scene. Does that give you any more information, any more thoughts? Can you rule out stuff? Can you rule in stuff? What are you thinking now?
Skin color's good.
Can't rule anything out, but if they're in the back of the car, then heat could be a problem. Or cold, depending on the temperature.
Sure. Okay. Can't grossly see any trauma. Of course, you haven't evaluated yet, but not obvious bleeding or anything like that, right? So you can gather some information visually. Okay, what do you want to know? I'm the mom, the patient, everything. What questions do you want to know? What exam findings do you want to know?
What past medical history does the kid have?
No significant past medical history.
Let's start with vitals.
Just how long has he acted like this?
Just today.
What happened?
The kid was fine this morning.
Has it ever happened before?
No.
Like, what happened
What we
that you
didn't
called
have started.
911 today? Like, did you go into the store, leave him in the car?
So I'm a terrible father. I left the kid in the car because she was screaming, I think she. And I went into Walmart and there were a lot of sales. And so I did a lot of shopping.
Black Friday.
Yeah.
How hot is it today?
And when I came out to the car, she was vomiting, then became altered. And so I called you guys.
How hot is it today?
It's warm outside. I don't know the exact temperature, but it's summertime. Yeah. So, great questions. Is it leading you down a path? Yeah. Vital signs were mentioned. Here's your vitals. Heart rate 152. Any thoughts with it?
How old are we saying this kid is?
It's
Like a year?
2, maybe-ish. Yeah. So, it's okay, right? It's nothing exciting. Blood pressure, does that get you excited?
On the bottom side of things.
Okay. It doesn't get me too excited, but it is what it is, right? Respiratory rate,
Good.
a little bit fast, right? Yeah, a little fast. Pulse ox 98, so great. There's your temp.
Not good.
That's the big giver right there, right? We were already thinking about that with our history. There's your glucose, normal. G-test of 9. So this little girl's in sad shape. So heat exposure, hyperthermia, actually anything over 101. So by definition, if you get a lot of illnesses and your temperature is over 101, you're quote-unquote hyperthermic. But as we know, with these illnesses, even though our temperature is greater than 101, we don't have all these other signs or symptoms that are concerning, right? So it's a spectrum, just like the hypothermia was. So risk factors for heat illnesses, hot outside, right? We're not able to radiate our internal heat. We're not able to get rid of heat when it's hot outside. If there's high humidity, you're not able to evaporate as much either. Lack of acclimation, so kids have a hard time acclimating, elderly people have a hard time acclimating. Vigorous exercise, even young people like us can become hyperthermic. Running marathons, that sort of thing. A lot of activity, your body just overwhelms itself with all the heat going on. So the beginning of the spectrum, heat exhaustion, this is the common stuff where you can have symptoms, but not necessarily a big, bad, ugly, dangerous, life-threatening issue. Fatigue, nausea, vomiting, headaches, these are all common symptoms of heat exhaustion. And then the more serious is the heat stroke. Less common, but incredibly serious and potentially life-threatening. So it's when your body can't regulate the heat anymore. It's overwhelmed with the whole heat issue and will result in death if not treated. Guaranteed. I don't know what happened there. Okay. I guess I just didn't do the individuals, but so typical situations that you're going to see it most commonly: physical activities, poor ventilated spaces that are really hot, either outdoors or indoors. No air conditioning or poor ventilation, like this kid in the hot car, left unattended. We hear that on the news all the time. It's called heat stroke because of the neurological symptoms. Okay. It's kind of an older term, but it's also been known as heat shock because you can get hypotensive with it. So those are just in reference to the symptoms that occur to your cardiovascular and neurological system. So treatment. Obviously get them out of the hot environment, get them into air conditioning, remove clothing. This is something we see in the ED almost daily. Kids come in with an illness, an ear infection, whatever it is, their temperature is 103, and they've got 3 layers of clothes on. Parents just don't quite understand that concept a lot of times. So get them undressed, get the clothing off. Put wet towels on them, get a washcloth, get it wet, put it on them. Spray them with a spray bottle, whatever. Help with that evaporation process to get that heat off. And then, of course, exclude other causes of altered mental status. Don't get blindsided that just because they have a high temperature and they're altered, it has to be heat exhaustion or heat stroke. Could they have a diabetic issue at the same time? Yes. Could they have had a stroke or an MI or, a variety of things, the toxicology, an overdose? I mean, just don't be completely blindsided. Let the vital signs, let the history guide you, but be open to other possibilities as well. Questions about heat? Okay, case 3. You get a call about an elderly woman at the aquatic center in full arrest.
Shooting the pet and stingrays.
Not aquarium, aquatic center, like a pool.
Okay, so what are you thinking about? What's your differential? What are you thinking about?
Is she in a drowning or was she just on the deck?
You don't know.
Nice.
Yes. But I'll be your history giver in just a moment. Okay, so drownings. That's a possibility you mentioned. Okay. What else is on your differential?
Got overdosed.
Overdose? Sure, always a possibility. Older people take lots of medications. Could they accidentally overdose or even intentionally overdose? Absolutely.
Did they bagel out in the bathroom?
Vasovagal syncope.
Always happens.
Bailed out on aerobics and.
Is it truly a cardiac arrest? Right? How many calls have you been on those like that, right? It's not really, they're not really an arrest.
Does she work with chemicals like the chlorine?
Okay, she could be a worker there in chemicals, great thought.
Just slip and fall, just hit her head and went into a full rest.
Trauma, I like it.
Cardiac.
cardiac, neurologic, I mean, the differential's huge on this, right? Particularly because she's old. So she could have lots of comorbidities. I mean, her body could she just could be dying. She just could be dead, you know, just done with life. So lots of possibilities on this. And then you have to kind of figure out, is the aquatic center of any relevance, or is it just coincidental that she was at the aquatic center? Again, what are you gonna do first?
Check a pulse.
Oh, vital signs, yeah,
The
right?
assessments,
Assessments, ABCs. Excuse me. This is what you see when you come on.
That is not an elderly home.
Give me a break, come on. There's only so many pictures on Google. At an aquatic center. What information are you getting now?
Still gonna check a pulse.
Yeah.
Definitely looks like a drowning.
So yeah, definitely possibility of drowning. I mean, you've got some lifeguards. You would assume they know a little bit of first aid. They know how to check a pulse. They know how to check for breathing. They're doing CPR. They've got a mask on her and doing rescue breathing. So you can probably pretty assume that she is in full arrest. These guys probably have a good assessment. But yeah, you get more information. Okay, what do you want to know?
What happened?
Does she have a pulse? She got Steve Irwin.
Well, that too, but like what, like I'm gonna ask the lifeguards, like what happened? Did she fall? Did she
Pull her out.
pull her out of the water?
So she was playing with her grandchildren in the pool and seemed to be doing fine, and then all of a sudden just went under. And then was pulled out in this.
Wondering cardiac.
So does it sound medical?
What does the EKG show? A system?
Is there a swim up bar at the pool?
We're in Layton. So heart rate, there really isn't any. She's getting CPR, so she has a heart rate with CPR. Blood pressure, you don't even check it, right? 'Cause it's not of any utility while you're doing CPR. Getting rescue breathing, no spontaneous breathing. Pulse is 68%. What information does that give you?
She's dead.
That she's dead. Great.
Possibility, I mean, in reality, it doesn't give you much, right? If it was a good pulse ox, then okay, great, good rescue breathing. She's got some good circulation going on. But if it's poor, you could still have good CPR, you could still have good rescue breathing. It doesn't help you a ton, to be honest with you. Temperature, 36.8.
That's all right.
Thoughts? Yeah, we're okay with that, right? Glucose, 145. GCS of 3.
What's her end tidal and her forelead?
Whoa, I'm a simple ER doc. 'I don't know.
24.
Sure. Great questions, and I should have put that on there. Thank you. I'll improve my PowerPoint. You asked about history, and that gave a lot of information. So then the question is did she drown, which can happen with adults, right? Or did something happen that caused her to go under the water? And that's what you're gonna have to try and figure out if you can revive her. So water, environmental emergencies, drownings, we all hate them. They suck, but in reality, they exist, and we have to deal with it, right? So essentially, you're being submerged or immersed in some sort of liquid, most commonly water, but can be any other type of liquid as well. Risk factors, alcohol consumption increases your risk for sure. Pre-existing seizure disorders, this is one of the worst cases I've ever had, was my neighbor who had a seizure. Still chokes me up. These suck. She was in the bathtub. Had a seizure, drowned. We couldn't revive her. These suck, but definitely a risk factor. Geriatric patients, so this is an old lady, does she have some sort of cardiovascular event? Did she have some sort of neurological event that caused her to go under and drown? Kids, we understand that process, unsupervised and not able to swim. Treatment, ABCs, right? Start with the basics. If you can resuscitate them, if you get ROSC, if they're able to survive, dry them off, rewarm them. These are the high risk hypothermia type of people that we talked about, right? History is important because it's a completely different animal if it's a teenager that dies off the side of the pool in a shallow pool versus an old person like we're talking about, right? So spinal injury, head injury, you have to obtain that history to determine what may have caused the drowning. If there was some sort of trauma, obviously C-collar, backboard, do all your trauma stuff for head and neck. And then consider other causes, like we talked about. So hypoglycemia is a diabetic issue. Did they have an MI? Did they have an arrhythmia? If you're able to resuscitate them, you get ROSC. What's their EKG show? Are they a STEMI? Get some information. Are they in heart block? Whatever. CVA, if you get response back to them, do they have a focal neurological examination? Have they had a stroke and their left side is weak and they just couldn't stand up in the pool and they fell over? So all this information is important if you can gather it. Oh, questions? Drownings? 2 types of drownings.
Wet and dry.
Wet and dry. What's wet?
And held a lot of water.
Water in the lungs, right? Causes a lot of pulmonary edema, so they'll have a lot of water coming out, not only from what they got in there, what they aspirated, but also the pulmonary edema. They'll classically have that frothy, bloody type of secretions coming out. So you go to intubate them, there's going to be fluid. After you intubate them, it's just continuous fluid. So suctioning is huge. Just continue suctioning. Okay, so that's wet. What about dry? What's dry drowning?
Cold water drowning.
Okay.
Technically.
Why is it dry? What do you mean by cold water? How do you connect those two?
Because it's shutting down. I forget what it does. It shuts.
It's like the mammalian something reflex, I can't remember. That.
Mammalian reflex.
Yeah, so essentially it's a laryngospasm. Your larynx spasms. It constricts. So it's complete obstruction. You can't get water down into your lungs. So when you encounter, if you're on scene and someone drowns and so forth, you don't know if it's dry or wet at that point. But it's important to get them out of the water quickly. If it's a dry drowning and they just had laryngospasm, that might relax, and if they're still in the water, then they could have a wet on top of it, right? Or secretions if they don't get intubated quickly. So just thought processes. But with dry drownings, they're going to have a lot of pulmonary edema as well. So you're going to get a lot of secretions and so forth. So in reality, does it matter? No. But information is helpful. Better chances of survival with dry drownings. Because you can imagine, you didn't fill your lungs with water, you had a laryngospasm. So if they get quick access to an airway and relax and so forth, greater chance of survival. You may have a difficult time intubating if it's laryngospasm. That's where paralytics are helpful, right? Any other questions? I know I didn't really pay attention to when we started. I know we're, time restraints. What do you need me to speed this up, stop,
No.
exit, keep going? Okay.
Depends how long you think you're gonna go. Are we talking 12 hours here? Rein it in, right?
For you, I would do that. No, not 12 hours. Case 4, I think there's I don't remember now, 5 or 6 cases, so. You get a call about a 49-year-old man with shortness of breath, vomiting, headache, he's up Adams Canyon. Okay,
Californians,
I'm sorry?
from California, right?
From California.
Funny deal.
We're not too far off. Well, it's interesting, this is actually my brother. I made this case after him. Because this occurred. So what are you thinking? What's on your differential?
HAPE,
Say again?
HAPE,
Ooh, I'm dumb. What's HAPE?
high altitude pulmonary edema.
Okay. I like it. What else on your differential?
Summertime, consider heat.
Yeah, heat exhaustion, we just talked about, right? Overexertion, okay?
Or did like me, almost stepped on a rattlesnake.
Oh, okay.
Could just be really out of shape.
Out of shape, absolutely.
Does this happen to you too?
Is it some sort of animal or something, intervention? Yeah, okay.
The bear.
Cardiovascular health.
Cardiovascular,
Your old male, maybe some pre-existing
sure,
cardiovascular.
absolutely.
Did he slip on the slate rock? Did he slip?
Is it trauma related? I mean, that's where you guys deserve all the respect, because the differentials in your job are huge. And the information is very limited. So you guys are, in my opinion, very well respected, because you have to have a lot of knowledge with a little bit amount of information. The tools you have are limited. You can't do a bunch of blood work like I can. So in some capacity, you guys are a lot smarter and a lot better at certain things than I am. And so kudos to you guys with your difficult job with huge differentials. Okay, again, what are we gonna do first? Some of the basics.
ABC.
Vitals.
ABCs, vitals, glucose, right?
History.
History. This isn't actually my brother. I respected him by not putting his picture on there, but this is what you see. Give you any more information?
He's pretty high up there.
It's pretty
See
cool.
the top of the peak.
That is a high Adams Canyon, right?
Above the tree line in Adams Canyon.
Okay. So he's awake, right? He's sitting. He doesn't look well. He's struggling. But he's awake, right? He's not dead. You're not doing CPR on this guy. So you can gather some history, you can gather some vital signs, get more information. Okay, what questions or what do you want to know?
Previous history.
Previous history, when he was a child, he had some heart issues where he had heart surgery. That since is resolved, no issues otherwise. He's had multiple abdominal surgeries with some obstructions and needing some resections and so forth. But otherwise is very functional, is on an antidepressant, but otherwise no other medications. Yeah, that's his past medical history.
When did this start and then where are you from?
Great question. He felt fine this morning, felt fine starting at the Adams Canyon. He grew up in Utah, but over the past 15, 20 years has been living in Boston. And then is here visiting.
When he talks to us, is he able to keep a conversation or is he having to take breaths before?
Short of breath, but able to talk in short sentences and give you the appropriate information.
What are
Does he have a
vital
headache?
signs?
Headache, yes.
He does?
Uh-huh.
Cool, we walk down.
I wanna know what our plan is to get him off the mountain.
It's your job, not mine.
Lung sounds?
Yeah, that's, what are his lung sounds, what are his vitals?
Okay. Here's your vitals. Heart rate 110. Blood pressure is fine. Respiratories are a little bit quick, but okay. Pulse ox 88%. Temperature's normal.
We're low.
Get any information from the vitals?
Not really. I mean, he's
Well,
not
he's
breathing
not
fab,
setting
he's not
this.
oxygenating fabulously.
So maybe some respiration issue a little bit there, right? Little insufficiency. Someone asked about breath sounds. Breath sounds are clear.
Does he have like a bug bite or maybe maybe he felt like he got bit by something? Or
Yeah, not that he reports.
No rash on the body.
Nope. So this is one of those cases where your differential maybe narrows a little bit, but it's still pretty wide, right?
Did it get progressively worse? Or did it come out of nowhere?
Great question, actually. Progressively worse. It was a slow process as he went up the hill. Why do you ask that?
Because I've had hate before and know how it happens.
Okay.
So, yeah, it's an altitude-related issue, if it's more than likely an altitude-related issue.
What would be your thought process if it came on suddenly? Why did you want to differentiate that?
Possible, like, just depends with the headache, the nausea, the vomiting. I was worried about like some sort of cerebral hemorrhage, basically, if it came out of nowhere.
I love it.
But with none of that, it's probably an altitude problem.
So that history taking is really key. So understanding what your differential is can help you with guiding you on your questions. So that question was perfect. Because it tells me you're thinking about your differential. So does he have an aneurysm that popped and had sudden onset headache and then these other symptoms from overexertion? Absolutely a possibility. So that's going to be a quick onset versus your HAPE is going to be a slower process, right? So questioning about where he's from is important. So all these things help you narrow your differential. So very good questions. What about pulmonary emboli?
It's possible.
He's from Boston, right? So he likely came by airplane, even if he drove. Either way, he's high risk, right? He's got a little bit of respiratory insufficiency, little low on oxygen, little tachypnic. So all great questions. Glucose was normal and GCS of 15. You may not always have the answer when you guys are out there. Your differential doesn't always get narrowed down immediately. You gotta leave some meat on the bone for me, right? You gotta let me do something. So don't always feel like you have to have an answer, and that's okay. But gathering some information is helpful in the process and can help guide you into treatments and so forth. History. I had an attending in residency that would not touch a patient. Kind of odd, I don't recommend it, but his point was he could gather all the information he needed by asking an appropriate history. By knowing his differential, asking detailed questions, narrowing it down and so forth, he knew what was going on just by history, even before examining the patient. I think we still need to examine. We still need to do vital signs. We still need to listen to heart and lungs, that sort of thing. Do a neurological examination. But history, in reality, is more important or more helpful than physical examinations. We saw that a lot with COVID, for example, when we were trying to keep our distance from people. I got in the bad habit of not examining patients during COVID, to be honest with you. I'd walk in the room, stay at least my 6 feet away, and talk to them, figure out what was going on, see vital signs, let the nurses touch them, you know, and so you can gather a lot and do a lot just from history if you know what you're asking. So, his issue, altitude sickness. Diminished oxygen in the air at high altitudes. Are we considered high altitude?
Yes.
Yeah, we can be. It's not the extremes that you typically think about, Everest, Machu Picchu, those types of places. It generally occurs over 8,000 feet. What are we here?
45 valley.
Yeah, 42, 45 in the valley, and then it goes up. I don't know what the peaks, what our peaks are at, and so forth. But we're under the 8,000. But it still can occur at lower altitudes. Does anybody know what our peaks are?
Thurston right there is the one that overlooks town, it sits just under 10. It's like
Okay.
99, 94.
So towards the top, so you are above the 8,000, okay. So it still is in your differential, you guys were on it, good job. Common symptoms, headache, nausea, vomiting, difficulty breathing, all the things that you would imagine. Edema, this is what I think about when I think of altitude sickness is edema. Where is the edema occurring and what problem is it causing? If the edema is occurring in the brain, what's it gonna do?
Altered mental status.
Altered mental status, headache, vomiting, right? So that explains your symptoms. If edema is occurring in the lungs, what's it gonna do?
Difficulty breathing, wet lung sounds.
Difficulty breathing, wet lung sounds, hypoxia, that sort of thing, okay? So you can just think of it simply as edema is what altitude sickness causes. Treatment?
Go down.
Yeah, go.
Oxygen. Slowly move down.
Go down, okay? Go down in altitude. What else can you do?
Oxygen.
Oxygen, absolutely. Anything else you guys can do?
If it's pulmonary CPAP.
I love that. If they have pulmonary edema, absolutely, CPAP. What can I do in the ER? Or what do I do? I'm sorry?
Diuretics?
Good. So diuretics, it's about edema, right? So we're making pee. So the most common medication for altitude sickness when traveling the world, when I travel with National Geographic, in my backpack I have a ton of acetazolamide, Diamox. It's a diuretic. That's the first line treatment for altitude sickness. Whether it's in the head issues or lung issues, altitude sickness, get the fluid off of them, okay? If that doesn't work, then the step above that are steroids, Decadron. And so those are the two main medications we use to treat altitude sickness beyond oxygen, get them at lower altitudes.
Would you do hyperbaric on this person?
No, too mild of symptoms. Yeah. In reality, hyperbaric is not as helpful with altitude sickness because of location mostly. So when you're on Everest and so forth, to get you to a hyperbaric chamber is extreme amounts of time. And so by then you've already had hours upon hours of oxygen. You can do diuretics, you get them down in elevations. So, you know, same thing with like Machu Picchu and so forth. So if you had quick access at a very high altitude, absolutely you could. But hyperbaric's probably more useful for the, you know, diving situations, diver sickness. Other questions? Okay, case 5. You get a call about an 87-year-old man unresponsive near a burning barn on his farm. Okay. What are you thinking? What's on your differential? What are you gonna do first? Same questions, we don't have to go through it all, but just be thinking about it, right?
If he ran in, good chance of hydrogen cyanide poisoning.
Okay. So the fire could be related to the fire, right? Any other thoughts?
Heart attack with stress.
Fire out.
Yeah. All your issues of old people, right? Yeah, stress related, MI, all that sort of stuff. Here's your scene. He's on the other side, you just can't see him. He's laying down on the other side of it. Okay, what questions do you have or what information do you want from history or exam?
Just right up front, if you see any trauma right off the bat, then you know you can move him immediately and not worry too much about stabilization.
Absolutely, I love it. Get him and yourself in a safe place if it's not obvious trauma. Perfect.
Is he in full arrest?
not in full arrest.
Does he have burns to the face?
No burns that you can, anywhere on his body that you can visually see.
In the airway itself?
Here's your vital signs. Heart rate 112. Blood pressure, textbook normal. Respiratory rate's okay. Pulse ox is fine.
Maybe they call me on that.
Temp is fine. Vital signs help you?
No, not really, no.
I mean, they all look good, right? It helps you rule out some stuff, but not necessarily rule in or guide you per se to what's going on.
Is his skin
Glucose?
condition normal? Like, I know his pulse ox says 95, but is he like blue
Or red.
or red?
Red. Or carbon monoxide.
I like where you're going. It looks normal from what you can see, but he's clothed.
Is there other people around to get history from?
Yes, his wife's there. Someone said blood sugar, 168.
What does she know happened?
Oh, he was unresponsive, I'm sorry, someone asked me that. I guess this guy's unresponsive.
What did wife say happened, and what's past medical history?
Again, one of those key things, history taking. So he wasn't able to give you history, I guess, because he's GCS of
It was
3.
the meth lab in the barn, wasn't it?
But his wife said, yeah, there's this bad storm that's been going on. He was worried about the animals being protected out into in the barn, and so he went out to go check on the animals. She heard a big clap and then looked outside and the barn was on fire.
What animals?
Animal? I think they had a
Maybe he got
giraffe.
kicked in the chest by a horse. Killed him.
They got kicked in the chest by lightning?
Even an elephant. I mean, it was quite the farm.
We strip this guy down. and we
Is there
see
any
him on the train
exit wound or anything? If we get in trauma naked?
Yeah, no, that's great. Yeah. So you disrobe this guy, and you do see some markings, classic lightning markings. Do you know what those look like? I should have gotten a
Feathers.
picture.
Like Harry Potter?
Sweet tattoo, basically.
As you can imagine, it's like a lightning on your torso or something like that. There may be exit wounds, there may be entrance wounds, that sort of thing. So physical examination of the skin is important in this one, as well as a detailed history as to what really led up to the event.
What's the EKG show?
I know, I was like, does he actually have
Pick 'em up to a monitor.
a pulse?
Yeah, his heart rate was what, 112? 112?
That doesn't necessarily mean he has a pulse.
Palpable, yeah. That's not on the monitor, yeah. Good question.
Patients, not monitors.
I like what you're thinking of. So let's talk a little bit about lightning. Excuse me. So these are the high-risk things. People in water, golfers with a iron club going up, those that are in large open areas or by a single tree, those types of things. The things we all understand and have heard about a million times. The things that are affected are cardiovascular and nervous, so asking about an EKG is very important because cardiovascular is hugely affected with lightning strikes. Respiratory or cardiac arrest, the most common cause of lightning-related death. These are things that we can help with, right? The most common causes of death we can help with. If they went into respiratory arrest, we can intubate them, we can breathe for them, that sort of thing. Cardiac arrest, if they're in arrhythmia, we can shock them, we can do things. So these are things that we can help with, the most common causes. If they have more internal injuries or neurological injuries from the lightning strike, that's a little bit of a different story. Less chance of survival. Treatment, protect yourself, protect him, get him out of the way. Great comments. And then your basic ABCs. So this guy needs to be intubated, right? Or at least some sort of airway intervention, oral airway, something. His GCS is 3. Okay, so he's not protecting his airway. And then assess and treat. Look for entrance and exit wounds. If you find burn wounds on him, how would you treat that?
Dry sterile dressing.
Just wrap it up. Dry sterile dressing. Perfect. Internal damage. These people can have their spleen just explode, their liver explode. You know, looking and examining them and evaluating for other potential organ injuries is important. So electricity injuries in general, this is kind of basic, we'll just go over quickly, but there's the AC versus DC currents, right? So what are examples of AC? Here, right? Yeah. So electric fence, outlets.
Use words.
Are you a fairy? What are you doing here? So it's the stuff where, you know, I remember as a kid, I grabbed onto the electric fence at home. And what do you think happened to me?
You didn't grab it again.
Are your extensor muscles stronger or your flexor muscles? Flexors. I grabbed on as a kid and I could not let go. All my hand muscles were activated and I could not let go. And my dad had to come pry my hand off of the electric fence. Outlets in the home. AC injuries are usually focal. So these are ones that you can visualize. You know, it's to the hand. It's I thought I had a picture here, but maybe it'll come up shortly. DC, what's DC examples? Direct current. No. Unless you're above the building, I guess.
Yeah,
Batteries.
Yeah, yeah. I'm sorry.
Anything chemically complex, like batteries, sorts of things.
Okay. Chemical stuff related, good. What are some of the most common DC injuries that you'll see?
Trying to
Beyond.
work on your Toyota Prius.
What happened to this guy, right? Lightning's a DC. It's just a boom. Direct current to your body. Okay? Power lines. These are the guys that get in touch with the power lines and they get thrown. It's just a direct boom. They get thrown from it, okay? More severe with the DC injuries. So the type of electricity is important, helps you evaluate what things to look for and what not to, and then secondary injuries from trauma. Was he thrown from the electrical post was he was working on it and so forth, and now has traumatic injuries on the ground as well. Those types of things. Oh, there's my picture. This is one that you might see with kids. How does this occur?
Battery.
Not battery specific.
Chewing on a cord?
Yeah. Infant or kid chewing on a cord that's plugged in. Burns them right on the corners of their mouth once they get through the plastic part or the rubber. Questions about electrical injuries?
Have you actually had a lightning strike emergency?
I haven't. Nope, I haven't. I've had some wires, some power, electrical wiring. I'm blanking on the word. You know those big. Thank you. I've had some power line injuries where they've had like an entrance and exit wound and that sort of thing, but I've never had a lightning. I think this is our last case. Receive a call about a man with an injury to his hand. Very vague, you don't know much information. We'll skip over what you're thinking, what you're going to do. This is out on the east bench of Layton. This is what you see. Any thoughts?
Purple. Stinger bite. Stinger bite.
Sting or a bite? Trauma? Do you think it's like a crush injury or anything like that?
Possibly.
Potentially, but seems less likely, right? You see like that wound, that puncture area, and then the bruising and the swelling around it.
Stingray.
The old Utah Ray.
We'll just cruise through this. I won't. Or do you want to play the game? Do you want to ask questions, or you want me to just go to the meat and potatoes? Meat and potatoes. Okay, vital signs. They look fine. Glucose is fine. GCS is fine. History. Out working in the yard, moving some rocks, came upon a startled rattlesnake and was bit. He took out his 9mm, shot the rattlesnake, went inside thinking it's okay, it didn't hurt that bad, it was a small rattlesnake. Took a rest.
Those are the bad ones.
Then woke up and started feeling nauseous, clammy, just not feeling well. Took a look at his hand and it was more swollen, more ugly looking. So obviously we're talking about snake bites. Just some information. 115 different snakes in the United States, and only 19 are venomous, so the majority are not. The ones that we worry about that are venomous are the rattlesnakes, the copperheads, the cottonmouths, or the coral snakes. What do we have to deal with around here? Rattlesnakes. Here's your pictures. There's the rattlesnake. Who knows what that is? Copper. Water moccasin. Coral. Good. Treatments, ABCs, right? When you worry about rattlesnake bites, it's the neurotoxins, okay? That can cause an effect. They can go into shock. If your neurological system's not working, you can go hypotensive, right? If your neurological system's not working, you can have respiratory issues. I don't remember the name of it. I just am now thinking of it now. But one of the tail signs of someone that's imminently going to go into respiratory distress is they get this quivering of their face. You see the muscles fasciculating of their face. That's the neurotoxin that's starting to work. And if it's in their face, then they're almost imminently going to affect the respiratory system. So if you see any of that, be prepared to intubate, be prepared to help with the airway. It has a name, but I don't recall. Obviously, you can give medications for symptoms.
Ambulance 51. Respond to fire test call at 199 North Ford Lane in Layton. Ambulance 51. Respond to fire test call at 199 North Ford Lane in Layton.
No, I think he's going to copy it.
Station 51, you can confirm that was a test only?
Keep going then. Antivenom. There is an antivenom for rattlesnakes. I've given this before for rattlesnake bites. So in severe cases where the finger is getting worse, you might lose this finger. They have neurological symptoms or respiratory symptoms. We definitely give antivenom. So it is available.
McKay and Ogden.
I don't know about Davis specifically, to be honest with you. I would probably doubt it, to be honest. I've given it at Ogden before. As you can imagine, it's not used very frequently, and so it expires and that sort of thing. So locally, it's available, but I'm not positive at Davis.
I've asked Alan up in the pharmacy, we don't have it.
Okay.
If we were to get it, we would get it from Ogden.
McKay has.
Do you guys have a threshold for giving that? Or is it just like, if in your opinion, the symptoms are getting worse and worse? Because the antivenom doesn't come without its own issues.
You're absolutely right.
And so what's the balance there for you?
You're going to get different opinions from different physicians. So you're absolutely right. I mean, you can get a serum sickness with the antivenom that has its own symptoms. So for me, it's just kind of a gestalt as how serious this is. For this guy looking at that finger, I probably wouldn't give it, to be honest with you, but I would observe him closely. If it started to look like he was losing circulation in that finger, then sure, absolutely, because then you're talking about possibly losing a finger. if there's any concern that is respiratory or neurological or any other, it's kind of a gestalt.
So what's the onset of the action for giving antivenom? Is it, like, within minutes you'll see improvement if it's going to work, or is it hours?
It's probably not minutes, but it's pretty quick.
Yeah.
I think I've given it 2 times. The one time I remember they had significant improvement within the first hour or 2. And there's not a threshold where you have to give it within a certain time period of after the bite. You can give it hours later and it still be effective if things were to worsen. So a lot of these, we'll observe them in the hospital and just watch closely, even if we don't give it, just in case we need to.
Another follow-up question with that. Since you guys don't have the antivenom at Davis, would it be better for us to take any severe snake bite patients directly to Ogden or McKay? Or can you guys get it quickly?
Yeah, we can get it quickly. The carrier system for this community in general, whether I'm at Ogden and need something from McKay or Davis or vice versa, we all have things that we share. So I think in general I would just go to the most appropriate place. I wouldn't try to always know where a certain antivenom is or not. I mean, we're going to talk about another antivenom, and for you guys to try and, I don't even know which hospitals have it. So I don't think you're doing the patient harm by just going to the nearest appropriate facility, because we can get it pretty quickly. There's good relationships with sharing of medications and antivenom and that sort of thing. So if you're in Layton, I think Davis is appropriate, or the Layton IHC, wherever you think is most appropriate, but I don't think I'd bypass, in my opinion. Just a little bit about some other animals or insects or ugly things. Spider bites are something you'll come in contact with. The only ones we worry about are the black widow or the brown recluse. Those are the ones that can cause serious issues or potentially life-threatening. It's just always hard to determine what spider bit who and what. And so that's what's very difficult with spider bites. Specifically for the black widow, you guys understand what it looks like in the classic hourglass and so forth. It's the females that are more dangerous than the males. They like dry, dark places. They don't hurt that much when they're bit, when the patients are bit. Sometimes they may not even know. They may just maybe feel a little something and then see the spider. So it's not incredibly painful. In the area, when it gets reactive, they can cause some symptoms, some spasms in particular. That's classic for black widow spider bites, and so we'll give Valium, Ativan, that sort of thing to help with the antispasms, as well as their associated anxiety. The main danger is the venom. It can be neurotoxic, and so symptoms are pretty basic. They're just systemic. It's that nausea, vomiting, malaise, I just don't feel good, blah, type of feelings. But it's the neurotoxic. If they have neurological deficits, that's the thing you're worried about the most. So ideally, take a picture of the spider or bring the spider just so we can verify. Yeah, most of these are not dangerous. They get over their symptoms within 48 hours and don't need anything. Usually not life-threatening, but occasionally it can be, for which you give the medications for basic symptoms, but then there is an antivenom for black widow specifically in the severe cases, the neurotoxic severe cases. So again, these are people that will oftentimes observe in the hospital for this 48 hours to see if they develop anything, if they need the antivenom.
Would it be the same for like a snake bite? We're gonna wanna keep like the bite level with the heart and then not push IV fluids through the affected extremity? Or does that have the same effect?
I think theoretically, maybe textbook, that sort of thing, but I think in reality, that's not gonna change that much.
Okay.
Yeah, I wouldn't worry too much about it. If, you know, sure, if you have a choice of putting an IV in the other extremity, you know, of course, do it that way. But if they have an amputation, or, you know, whatever the case is, or, it's not the end of the world to put an IV in the same extremity. But you just don't know what the future holds for this person, how far the symptoms are going to go. Are they gonna develop cellulitis that extends up their arm, where an IV may be in the way of treating. And so ideally stay away from the injured area if possible, just like with trauma. But it's not the end of the world if you have to use it. Regarding holding it up and that sort of thing, your body's gonna circulate blood, right? So treat it for symptoms. If it feels better to elevate it, absolutely, great. Feels better to put ice on it, great. But we don't recommend like tourniquets, you know, that sort of thing to decrease the blood flow like you see in the movies sometimes. Does that answer your question?
Yeah. Thank you.
Anything else with Black Widow? Have you guys seen a Black Widow bite? They're not uncommon in Utah. I've seen multiple. Brown recluse. This is what they look like. I mean, classically, they have this violin-shaped mark on. The couple brown recluse I've seen I can't say I saw a violin, but that's classically how it looks. We do have them. They're less common than black widows here. They like the same sort of thing, dark areas. Their venom is cytotoxic, meaning it kills the cells. So these are the ones that look nasty. These are the ones that their finger falls off. It looks like gangrene. They get a big black sore on their stomach from where the bite was. So these are the ones that look nasty. The black widow bites don't look nasty at the site. They might get a secondary cellulitis or something on top of it, but these are the ones that are nasty and oftentimes have to go to surgery to have it debrided and so forth because it literally kills the cells in the area. Tissue damage, not painful initially, but becomes painful once the cells start dying, as you can imagine, within hours. And then anyway, we talked about that. Treat the symptoms. There is not an antivenom for brown recluse. So it's treating the symptoms, treating the wound is what the treatment is for that. Debriding. These people oftentimes go to the OR to have it all, but usually a couple days later after the tissues died. Just basic Hymenoptera or Hymenoptera stings, you know, bees, wasps, you guys see all this sort of stuff. Typically not a medical emergency, right? Usually just a local reaction, so you can just treat it symptomatically. However, you do have those occasional cases where you get angioedema or anaphylaxis. So those are the things you're looking for. Epi, right? The treatment. How much do you give?
0.5.
0.3, and what was the? 0.5.
For our protocol, yeah.
Is that a new recommendation, or I haven't heard 0.5?
I think our protocol says 0.3 to 0.5.
Okay. I give 0.3. We give 0.3 in the ED. Yeah. I don't know the literature behind 0.5. I'll have to look that up. I haven't heard that before. What about in kids?
It is.
Yeah, you can do it kilo based, or you can just kind of wing it. I kind of just remember half the size of an adult, you know, say 30 or 40 kilos or smaller, you give half the dose. So you give 0.15, you know. They have junior EpiPens that are just half the dose of an EpiPen. How do you give it? What route? Not PO? IM is another option if for whatever reason you don't do it IM. Can you give it intraocular? No. Dumb question. Can you give it IV?
You could do push dose if they're hypertensive, but preferably no.
It's not ideal, right? It's not ideal to give it IV. You can give it sub-Q as well as IM, just as effective. But IM or sub-Q. I once had a nurse give IV for an allergic reaction. And they got really hypertensive and really tachycardic and didn't feel great. But they didn't have an MI, so we didn't have that big of an issue. But you can overload the heart if you give it IV, so you have to be careful. Tick bites, we have these in Utah. We're just gonna. Are you okay if I just go quick? Because I feel like I've talked too much. You guys know all this sort of stuff. Just a couple things that we can see with tick bites in Utah that's specific to Utah. Rocky Mountain spotted fever usually occurs a week or so after the tick bite. A lot of tick bites people don't know about, and so this is difficult to find history on. But it's helpful if someone comes in with a rash and with a fever, and it's just not clear what's causing all this, to gather history. Oh, I was camping in the woods a week ago. Okay, there might be a tick bite involved, you know. So symptoms are just going to be your basic stuff. The rash is pretty classic, and I have a picture here, but they're just going to feel terrible. But that's pretty classic rash for Rocky Mountain spotted fever. You can see the spots, right? They get high fevers. Pretty classic rash. We also get Lyme disease, or can get Lyme disease in this area. This also has a pretty classic rash, a bullseye rash. And then they oftentimes will have joints that ache. Usually it's the larger joints, like the knees, the hips, and so forth. Not just a full body, all my joints hurt, but specific joints. That's the classic rash. Literally looks like a bullseye. Okay, quick test questions. When a person is exposed to cold temperatures and strong winds for an extended period of time, he or she will lose heat mostly by radiation, convection, conduction, evaporation. Oh, that was quick. What's the answer? Convection. Yeah, conduction. Or convection, excuse me. I misspoke. Okay. Shivering in the presence of hypothermia indicates what? That the musculoskeletal system is damaged, nerve endings are damaged, body's trying to generate more heat, or the system has failed. Sorry? C. Yep, body's trying to compensate for it. I told you this test was easy. Woman has frostbite. Both her feet after walking several miles in frozen field. Her feet are white, hard, and cold. The touch treatment at the scene should include rubbing her feet gently with your own warm hands. Trying to restore circulation by helping her to walk around. Removing her wet clothing and rubbing her feet briskly with warm, wet cloth. Or removing her wet clothing and covering her feet with dry, sterile dressing. D. D as in dog? Feel that. Yep.
Feel that.
Don't rub her feet. 30-year-old male has been playing softball in the hot environment, complains of weakness, nausea, shortly after experiencing a syncopal episode. Appropriate treatment for the patient includes all the following except giving a salt-containing solution by mouth, moving him to a cooler environment, administering oxygen if needed, placing him in supine position and elevating his legs. Which one do you not do?
A.
Why?
wanna give people stuff in their mouth, especially if they're nauseous and vomiting.
Perfect. You don't want them aspirating, right? All right. It is important to remove a drowning victim from the water before laryngospasm relaxes because, I forgot I had a question on this, we talked about it. So you better get it right. Suffer less airway trauma, risk of severe hypothermia is lessened, less water will have entered the patient's lung. You can ventilate the patient with laryngospasm.
See.
That's so uncomfortable.
Good job. 3 ambulances respond to a golf course where a group of 6 golfers were struck by lightning. What were they doing in a group of 6? 2 of the golfers are conscious and alert with superficial skin burns. The next 2 have minor fractures and appear confused. The last 2 are in cardiac arrest. Which group of golfers should be treated first? Group 1, the ones with burns. Group 2 with the fractures and confusion. Group 3, cardiac arrest. Or groups 1 and 2, group 3 should be tagged as deceased.
Yeah,
Say again?
we're following triage protocols, then technically D.
Okay, so triage protocols would teach you D. Everyone agree with that?
Like how we'd actually do it, or?
Okay. Do you not follow protocols?
No.
Oh. Okay, so what are your thoughts? Are you thinking something different besides the protocol, the classic triage protocol?
We got 3 ambulances responding.
Yeah. We have,
Okay, how does that change your thought process?
well, someone could get started on cardiac arrest right away. That means you have 6 people triaging 6 people, more or less. Yeah, more resources.
So if you're the first crew there and you really have to triage, you really have to decide who to help. This is the only one I can think of that goes against the classic triage recommendations. And the reason is because what we talked about, lightning strikes, this is where you can make a difference. Cardiopulmonary arrest. So someone in cardiac arrest may just be in VFib that needs shocked and you save their life. They just may need their airway opened up or airway intervention, you can save their life. So this is the one case where if they look dead, you actually go to them first because you could make a difference. So they actually call it reverse triage in lightning strike situations. Does that make sense? Does that seem reasonable to go against protocol in this case? Don't tell Mark that I told you to go against protocol. Okay. Isn't that so true? No one ever calls you guys to say thank you. No one ever calls you guys to show their appreciation. They're always suffering, they're always complaining of something. So, I hope you guys understand that we appreciate you at the hospital, and as a community person as well, I appreciate you. Questions from anyone about any environmental stuff that we haven't covered or did cover? Or any concerns about Davis, or if you have concerns about me, you can talk to Jolynn. Anything we can do for you guys in Layton as a hospital?
EMS room needs a little help.
How so?
It's a safe environment, right?
Just like that.
Let's hear it. What? You're gonna have to expound a little.
So
bit.
No, I know it has nothing to do with you guys. People get busy.
No.
Just
Yeah.
putting
I
AC.
think,
stocking it?
honestly,
Yeah.
maybe from now that I've done clinicals there, I love that nurses take such good care of the patients there, and they're like, can I get you guys a snack? Can I get you anything? But they go take that from the EMS room, which is
Yeah.
understandable, like a
Gotcha.
perfect patient advocacy, but then it's like, oh, the EMS room's empty.
So is that frequent? I actually don't go in the EMS room very often, so I'm ignorant. Is it frequent that you guys, that it's not well stocked?
Especially on the weekends, they're supposed to stock it twice a day, but they don't ever stock it in the afternoon or evening. They only stock it on the weekends, and on the weekends they don't stock it at all.
Do you know who's responsible? Is it dietary? Hey, I will push. I don't know, I can't promise anything, but that's easy. I can try and make it happen. Okay, anything else?
That's probably not something that we're really, truly worried about.
No, that's fine.
I feel like that was a let in with joke.
Yeah, it was kind of more.
It should be an easy fix, so. Anything you're truly worried about, or we can talk offline if it's uncomfortable. I really believe in Davis Hospital. I believe in the emergency department. I know we've had some struggles over the years with various issues, but we're not fans of Stewart, who owned us before. We are fans of our new owners, and we're seeing improvements, and so I'm very optimistic. But even beyond that, I'm totally open to suggestions or complaints or anything you think we can do to improve. We want you guys wanting to bring patients to us. That's our goal.
Where'd Roxanne go?
Anything else, or I took too much of your time?
Oh, thank you.
Thank you. You might be the only one that can answer it too. I don't know.
I actually had a quick clarifying question, if you guys can hear me.
Yes, please.
At the beginning, I potentially heard you say that you guys were a trauma 2 center. Is that correct? Or you guys?
Oh, I misspoke. We're a trauma 3. I apologize. Yes.
Okay.
Thank
I
you.
just wanted to double check
Thank you for clarifying. Yes, we're a trauma 3. Ogden and McKay are 2s. We and the IHC are 3s. Thank you for that clarification. Anything else? Okay, you're welcome. Thank you. Thank you.